Okay, good evening, everyone. Thanks for joining me in this talk. Today, we're going to talk about some new things. We're going to talk today about the right ventricle, okay? And we're also going to discuss today about tricuspid valve. And I hope all of you can hear me nicely. So we're going to start now, okay? Let's talk about the basic of the heart. Okay, so I'm sure that all of you have already know about the heart anatomy. And this is the echocardiogram view of the heart. Okay, for those of you who are not familiar, right? So it is annotate here. This is left atrium, left ventricle, and also right ventricle. So the heart contract in three ways. One is longitudinally, okay? So that's this way here, okay? Another one is radially. So this is when you look at the parasternal long axis view and you see the thickening of the wall. And also circumferentially, in which the apex rotate anti-clockwise and the base rotate clockwise. So this combination of longitudinal contraction, radial contraction, and circumferential contraction is the one that causes the heart to contract to an ejection fraction that is 52 to 72% for male and 54 to 74% for female. Now, throughout today's talk, we're actually going to concentrate on this chamber on the right side of the heart, which is the right ventricle here. And also we're going to look in detail on tricuspid valve. Tricuspid valve is one of the most trickiest valve to determine what leaflet is there. So there is normally three leaflet in the tricuspid valve. So one is septal, another one is anterior, and another one is posterior leaflet. So today I'm going to show you how to determine which leaflet is which when you look at 2D echocardiogram. And the advance of 3D echocardiogram have made this very simple. When you look at this echo here, one of the things that I wanted you to remember and to realize is left ventricle and right ventricle share the same interventricular septum. So they share this wall, the interventricular septum. Okay. Therefore, anything that happens in the left ventricle can affect the right ventricle because some of the way the right ventricle contract is by pulling forward of the wall of the right ventricle when the interventricular septum contract. Okay, as you can see later, the left anterior descending artery actually supply the mid and apical part of the interventricular septum and also the moderator band of the right ventricle. So if you have anterior myocardial infarction, it is possible for the right ventricle to be involved because the septum is involved and also the moderator band is involved. And this interventricular septum is also the reason for interventricular dependence. What does interventricular dependence mean? It means that whatever that is happening on the left ventricle will affect the right ventricle. Whatever that is happening on the right ventricle will affect the left ventricle. Okay. Therefore, in respiration, when you inspire and expire, there is differential flow on the right ventricle that also causes differential flow in the left ventricle and vice versa. So that is the basic, and we're going to go in detail about this. So this just wanted to show you the arrangement of fibers of the left ventricle and right ventricle. Now, whereas the left ventricle can contract in three different directions, longitudinal, radial, and circumferential, the right ventricle is mainly longitudinal contraction. Okay, so therefore, most of our measurement of function of right ventricle is a measurement of longitudinal function, such as our S prime, which is the tissue velocity, such as our TAPSE, and TAPSE is one of the most reproducible measure of right ventricular function. For those of you that is interested in advanced echocardiogram, for example, when we want to do strain from speckle tracking, so when we do right ventricle strain, we mainly do longitudinal strain. The left ventricle, we also do longitudinal strain, which is the most robust we have, but there is also the other strain, such as circumferential and radial strain. I just wanted to remind you the normal value of strain for the left ventricle is about negative 18%. For the right ventricle, if you count the interventricular septum together, it's about negative 70%. For the free wall of the right ventricle without interventricular septum, it is about negative 19%. Okay. And of course, the left atrium and right atrium also have their own strain value. So the left atrium, the normal strain value should be about 42% and above. However, we take 26% as the threshold of abnormalities for the left ventricle. For the right ventricle, it's about 22% as the threshold of abnormalities. Okay, so it's the normalized strain value. So the reason I tell this is just, I only gotten to know this normative value for all the chamber cavity, and I wanted to share with you together here. So just the first echocardiogram for you to see today. All right. So this is actually someone that have rheumatic tricuspid stenosis. Okay, so this is actually a Mayo format. Okay, so I forget to label here. So in Mayo Clinic, okay, and I will tell you whenever I'm showing echo from Mayo format, the right ventricle is actually here on the left side of your screen, and the left ventricle is actually here. So you can see this patient. So this patient actually have tricuspid stenosis. You can see this, sorry, this is right ventricle, so this is not Mayo format, I apologize, okay? You can see the right ventricle here, and you can see the leaflet here. There is doming of the leaflet during diastole. And you can see again, I just play to you, doming of the leaflet during diastole, okay? So this is rheumatic tricuspid valve disease. So if you never see rheumatic tricuspid disease, so that is an example of rheumatic tricuspid valve disease, okay? Again, I want to correct myself. This is a normal echo, that is the right ventricle, left ventricle. As you can see, the mitral valve have rheumatic changes, and the tricuspid valve also have rheumatic changes. Okay, you can see the doming of the tricuspid valve. Okay, so it's a rheumatic tricuspid valve stenosis here. Now, remember I show you the cavity of the heart. So the left atrium, right atrium, the left ventricle, and right ventricle. Now, to be totally accurate, when you look at the echocardiogram, you cannot say whether the left atrium is left atrium because it's on the left side of the heart, or the left ventricle is the left ventricle because of the left side of the heart. So what I wanted to tell you as well, that each of cardiac chamber have its own morphological character that define them as left atrium, left ventricle, and right ventricle. Okay, so let's look at the embryology of the right ventricle first. So the right ventricle actually developed from the region of the heart tube. So the heart actually developed embryologically for a structure called a heart tube. So it's like a long tube, okay? So this long tube has different region, and this different region of the heart tube actually develop the structures of the heart. So one of the region of the heart tube is called the bulbus cordis, and the bulbus cordis is the region that developed to become right ventricle. And also, the bulbus cordis also contribute to the left ventricle and right ventricle outflow tract. So this bulbus cordis is responsible for right ventricle and also for the left ventricle and right ventricle outflow tract. Now this is important because there is a congenital heart disease that is called double outlet right ventricle, and because you understand now the embryological mechanism in which the heart developed, where in development the structure that gives rise to the right ventricle also gives rise to the left ventricle and right ventricular outflow tract. So it makes sense that the entity called double outlet right ventricle is present. Another region of the heart tube just on top of the bulbus cordis is called truncus arteriosus, and this truncus arteriosus actually become what we call a pharyngeal arch. All right, so this pharyngeal arch, there is 6 arch in total on the left side and on the right side, and arch number 4 usually develop the aortic arch, okay, and arch number 6 become the left and right pulmonary artery. Okay, so on the topmost part of the embryological heart tube is what we call truncus arteriosus, and this become pharyngeal arches, which then will become, some of them become aortic and some of them become pulmonary artery. Okay, so as the right ventricle and the left ventricle is defined not on its spatial orientation, rather on its intrinsic characteristic, it is important to know what is the characteristics that define the right and also the left ventricle, right? I just wanted to remind you because I find it fascinating when you wanted to learn about the heart, especially you wanted to learn about congenital heart disease, to understand the development of the embryo. So we know that embryologically we have 3 different layers. Okay, so we have 3 different cell layers at the beginning. So we have the endoderm, we have the mesoderm, which is at the middle, and we have the ectoderm, and this is the layer here, okay, in the embryo. So we have 3 layers there. So as the heart develop, it actually will loop like this, okay, so it will fold around itself. So what happened is the mesoderm layer, some of it develop, some of it contribute to the development of heart tube, and I will show you heart tube next. All right, so this is the primitive heart tube. So at the beginning you have this 2 tube here, which later at the day 21 of embryology it will fuse, okay, so you have a single heart tube like so. On the 22nd days of gestation, you can see that it become a single heart tube like this, okay. So you can see this, okay, there is 5 area that I wanted you to remember in primitive heart tube. The most top one is truncus arteriosus, okay. This will become the pharyngeal arch, so that's the pharyngeal arch here. So the truncus arteriosus will actually develop to become your aorta, your pulmonary artery, and also the other arches will develop to become PDA, patent ductus arteriosus, will become your subclavian, and will become your common carotid artery. That's all come from pharyngeal arch from the truncus arteriosus. Now the bulbus cordis, remember, contribute to the right ventricle and also to the outflow tract of both left ventricle and right ventricle. Now because bulbus cordis contribute to left ventricle and right ventricle, is the development is arrested before it's complete, you have this entity called double outlet right ventricle, okay. And the bottom here is the primitive ventricle, which will later become the left ventricle, okay. The primitive ventricle will later become the left ventricle. Now at the bottom of primitive ventricle, okay, you have the sinus venosus. So just one more layer here that is not written here is sinus venosus, and the sinus venosus actually will develop and become the smooth wall of the right atrium. So the sinus venosus will become the smooth wall of the right atrium. Then you have this primitive atrium here that actually will become the left atrium. Okay, so I just remind you again, this atrium here will become the left atrium, and this sinus venosus here will become the smooth surface of the right atrium. All right. Now, what happened is this tube, okay, you can see here the truncus arteriosus, the bulbus cordis, the ventricle, the atrium, the sinus venosus. So what happened is at first you have a tube that is straight like this, okay. So this is your truncus arteriosus, and at the bottom here is your sinus venosus. But the left ventricle will loop. What do I mean by loop is, rather than straight structure like this, it will loop and become like that, okay. So at the beginning it is like that. The top is truncus arteriosus, at the bottom is sinus venosus. During the 24 days of gestation, the heart will loop and become like this. So when it loops and become like this, so now you have the familiar arrangement of your left ventricle. So this is your atrium. Atrium go to the ventricle, and then go to the right ventricular outflow tract. So this shows the looping of the ventricle. Okay, so that's the truncus arteriosus, bulbus cordis, the ventricle. So this ventricle will develop to become the left ventricle. Now, as you notice, during the beginning of the embryological development, this ventricle actually connected solely to the atrium. Okay, so both atrium, the left atrium and the right atrium, at the beginning is connected only to the left ventricle. Now, if the development of the heart is arrested at this part, you have a condition that is well known in congenital era, which is double inlet left ventricle. Okay, so you know from this embryological development the logical explanation why we can have something called double outlet right ventricle and why we can have something called double inlet left ventricle. All right, so I just wanted to summarize. This is after the ventricular looping has complete. So what happened is, you can see that it has already differentiated to right atrium and left atrium. Remember that right atrium come from the sinus venosus, left atrium come from the primitive atrium, and the primitive atrium also contribute to the left atrial appendage and also for the right atrial appendage. Okay, now this ventricle actually will become the left ventricle. This left ventricle will actually fuse together with this part of the bulbous cordis that become right ventricle, okay, and the bulbous cordis will also give rise to the left ventricle and right ventricular outflow tract that then give rise to pharyngeal arch artery here. And this pharyngeal arch artery will then become your aorta and also your pulmonary artery. Okay, I hope the explanation is clear of this complicated development. So this is the positioning of the heart chamber during embryological development. So you will develop your endocardial cushion and the wall will come from top down here and also from side to side. And finally, you will have your atrial chamber and also you have your ventricular chamber and the development of right ventricle and also left ventricle. Therefore, as you look here, the leaflet of the each ventricle actually come from their own wall. So the left ventricle, the mitral valve actually come from the wall of the left ventricle that is delaminated, and the tricuspid valve actually come from the wall of the right ventricle that is delaminated. So one of the characteristic of the left ventricle is it will always bring its mitral valve together with it. And one of the characteristic of the right ventricle is it will always bring the tricuspid valve leaflet with it. Okay, so I hope you understand that. So what define the left ventricle and right ventricle in embryological sense? So this is the thing that you wanted to see it echo to say that it is right ventricle or left ventricle, not just their special relationship. Okay. Number one, so I just show you all the characteristic first, and then we'll talk one by one. If you look at right ventricle, the septal surface is coarse compared to the smooth septal surface of the left ventricle. Now, in the right ventricle, so right ventricle got the tricuspid valve got 3 leaflet. Some of the chordae tendinae from the septal leaflet of the tricuspid valve actually attach directly to interventricular septum. Okay, so this direct attachment of chordae tendinae to interventricular septum does not happen in left ventricle. It only happens to right ventricle. So that is very special. So in left ventricle, all of the mitral valve leaflet actually attach to the papillary muscle. None of them go straight to the interventricular septum. So that's the second characteristic. The third characteristics, if you look at left and right ventricle, right ventricle is more trabeculated. Okay, if you see in echocardiogram 2 ventricle, you don't know which is which. The one that is more trabeculated is usually the right ventricle. And another characteristic of the right ventricle is the presence of moderator band. Okay, and left ventricle, the trabecular is fine and crisscross. And I told you just now, the right ventricle carry with it the tricuspid valve, and the left ventricle carry with it the mitral valve. So if you look at apical 4-chamber view of the left ventricle, which ventricle have the more apical insertion of their leaflet, meaning the tricuspid valve, that is the right ventricle. So therefore, one of the clue that you are looking at a condition called congenitally corrected transposition of great artery, in which the right ventricle go to the left and the left ventricle go to the right, is you see in apical 4-chamber view on the left side, the leaflet is attached more apically. So you think to yourself, okay, this leaflet is attached more apically, so this must be tricuspid valve. If this is tricuspid valve, it is must attach to the right ventricle. So therefore, in this particular echocardiogram, we are looking at congenitally corrected transposition of great artery or L transposition of great artery. Okay, anything that you're confused, please ask me later. This is some facts of the right ventricle. It has different pressure volume loop compared to the left ventricle. So this is important because right ventricle actually tolerate afterload very, very poorly. Now, if you have systemic hypertension, this is a normal hypertension, your left ventricle can usually stand that hypertension because the left ventricle have a thick wall. Now, the right ventricle have a small wall. Therefore, if you increase your pulmonary artery pressure, the right ventricle cannot stand and it becomes weak very, very soon. Right? So pulmonary hypertension is poorly tolerated by right ventricle. Now, I told you already the right ventricle is mainly longitudinal contraction. It's interact with the left ventricle through the interventricular septum. One of the things that is special about the right ventricle is the inlet, meaning that the inlet portion that going into the right ventricle and the outlet that going to the pulmonary valve is not in fibrous continuity, unlike inside the left ventricle. I talk about the trabecular that is coarser in the right ventricle. I talk about the presence of moderator band. So the moderator band is something that go horizontal across the right ventricle, then there's also another band called septomarginal band. So you have moderator band from the anterior papillary muscle go straight to the interventricular septum. Then from the interventricular septum, you have another band. From that, go upwards through the right ventricular outflow tract that is called septomarginal band. It tolerates volume overload better than pressure overload. This is an important fact. What is this important fact? The commonest congenital heart disease, apart from bicuspid aortic valve, is atrial septal defect. And in patients with atrial septal defect, they have right-sided volume overload, and patients with ASD actually tolerate ASD quite well. That's why there's a lot of time we see someone with atrial septal defect, we only diagnose atrial septal defect in adulthood. Okay, and even in adulthood, we still have time to close the ASD and the right ventricle can recover. And a patient with volume overload on the right side develop pulmonary hypertension, much less common than rather patient that develop volume on the overload on the left side. For example, people with ventricular septal defect or people with patent ductus arteriosus. What is the difference if you look at the wall thickness of the right ventricle and left ventricle? So the right ventricle, the thickness seldom exceeds 2 to 3 millimeter. Anything that is more than 5 millimeter for right ventricle is considered abnormal. For left ventricle is from 8 to 11 millimeter. Now I like to use 10 millimeter as threshold for the left ventricle. Distinct pattern of contraction. So in the right ventricle, the main contraction is longitudinal. You also have peristaltic motion from the inflow to the apex and then to the outflow. And lastly, the importance of bellows effect. So let's say in your exam, someone asks you what is bellows effect. So bellows effect is the contribution of interventricular septum to pull the free wall of the right ventricle towards the interventricular septum. They have a higher proportion of alpha-myosin heavy chain isoform. It is more rapid but less efficient contraction. It generated less than 1/6 the work of left ventricle but moved the same amount of blood. There is less chamber thickness and lower ventricular elastin. It is more afterload dependent than left ventricle. Just as the pulmonary develop pulmonary hypertension, the right ventricle will start reducing its cardiac output. Now, this is the anatomy of the right ventricle. So I just wanted to show you the left ventricle, the wall is thicker, the trabecular is finer. The right ventricle, the wall is thinner, the trabecular is coarser. Tricuspid valve usually have 3 leaflets, but as I will show you later, we can also have 4 leaflets or 2 leaflets. So there is variability in the number of tricuspid valve. Okay, and mitral valve usually we only have 2 leaflets. Now, when you look at tricuspid valve, it should attach at the interventricular septum more apically compared to mitral valve leaflet. Okay, that is one of the main characteristics. This is looking at the tricuspid valve leaflet. Okay, now you can see that this is the mitral valve, that's anterior mitral valve leaflet, that is posterior mitral valve leaflet, that is tricuspid valve. We have a septal leaflet here. How do I know this is septal leaflet? It is actually just beside the interatrial septum. That is anterior leaflet. How do I know this is anterior leaflet? Because it's at the front, and this is posterior leaflet. And I will show you later how to recognize this criteria in echocardiogram. Now, when we were cutting, for example, those of you who do echocardiogram know when we do 4-chamber view, and this is a very familiar view for us, we are cutting at different direction depending on different tilting of our ultrasound probe. Now, this is a apical 4-chamber view. But in this apical 4-chamber view, we're actually cutting of the septal and the posterior leaflet of the tricuspid valve. Okay? If we were to just go a little bit anteriorly and we cut our apical 4-chamber view there, we're actually going to see the septal and the anterior leaflet of the tricuspid valve. So how do you want to differentiate in apical 4-chamber view, which of which? Now remember, as we go backward, okay, we will start to see coronary sinus here. So whenever we start to see coronary sinus, the leaflet that you see at the other side is the posterior leaflet. When you go at the front and you start seeing the aorta, whenever you start to see the aorta, the other leaflet is the anterior leaflet. Okay, coronary sinus is posterior, aorta is anterior leaflet. We also have this cutting here. So this is our long axis view. Okay, so we have anterior leaflet of mitral valve, posterior leaflet of the mitral valve, transecting the aorta. So you could actually see the aorta here. Okay, and we can measure the aortic dimension there as well. Now, from there to there, okay, meaning that from the left atrial appendage to this side here, this is what we call a bicommissural view. What do I mean by commissure view? It is from commissure to commissure, from the anterolateral commissure of the mitral valve to the posteromedial commissure of the mitral valve. Usually when we do this in echocardiogram, we will transect the leaflet of the mitral valve P1, A2, and P3. Okay, P1, A2, and P3. This is very important to determining in mitral valve which scallops is involved in certain pathology, right? This is echocardiogram looking at the side of the ventricle. I just wanted to show you the orientation of the right ventricle and the right ventricular outflow tract. Again, this is the leaflet of the tricuspid valve, the septal, posterior, and anterior leaflet of the tricuspid valve, and go right to the right ventricular outflow tract and into the pulmonary valve here. Okay. Now, this is the surface of the right ventricle, and you can see that the trabecular is coarser. Okay, in this patient, we can't really see a big moderator band, so that is a moderator band there. That is not quite big. That is a septomarginal band there. That is the septal leaflet of the tricuspid valve. So the blood will flow like so. So the blood will flow from the SVC into the right atrium here, from the right atrium into the right ventricle, for the right ventricle out into the right ventricular outflow tract. Now that I'm showing you this, I wanted you to give tips in terms of the naming of the ventricular septal defect. Normally, there are 4 different types of basic ventricular septal defect, and sometimes it's difficult for you to remember which is which. Now today, I wanted to show you the easiest way to remember which is which when you talk about ventricular septal defect, okay? As the blood go from here to here, any hole here is called inlet ventricular septal defect, inlet VSD. Now, inlet VSD is a spectrum of AV canal defect. This commonly occur in association with someone with trisomy 21 or Down syndrome. Okay, so that is an inlet VSD. Inlet VSD also the one that is commonly occur with primum ASD in someone we will call AV canal defect. Now, as you go a bit further down to the apex, and you can see this is actually very muscular. So if you have hole somewhere here, that is called muscular VSD. Now, vascular VSD is the most common VSD in childhood. The reason we don't see muscular VSD as much in adulthood is because this normally will close spontaneously. All right, so that is muscular VSD. The next VSD is the one that going out of the heart, below the pulmonary valve and adjacent to right coronary leaflets of the aortic valve. So this is outlet VSD. Outlet VSD have many different names such as supracrystal VSD, infracrystal VSD, but all of this actually just a variant of outlet VSD. And lastly, between this VSD and this VSD, you can have VSD at the membranous portion of the heart, just beside the septal leaflet of the tricuspid valve and right coronary cusp of the aortic valve. That is called membranous VSD. So very easy to remember this 4 type VSD. I remind you back: inlet VSD, muscular VSD, outlet VSD, and perimembranous VSD. Because we know that perimembranous VSD is adjacent to the right coronary cusp and septal leaflet of the tricuspid valve, we know that some of the complication of perimembranous VSD is you can have prolapse of the right coronary cusp or prolapse of the septal leaflet of the tricuspid valve. If you have outlet VSD, you can also have prolapse of the right coronary cusp, but not prolapse of the leaflet of the tricuspid valve. So that's how you remember ventricular septal defects, looking at the surface of the right ventricle. I wanted to show you here also what does pulmonary valve look like. It looks like this, okay? It also have 3 leaflet. So we call the leaflet right leaflet. So right leaflet is the same orientation as right coronary cusp of the aortic valve. You have the left leaflet, the same orientation as left coronary cusp. And you also have what we call an anterior leaflet of the pulmonary valve. So this is the leaflet that is most anterior inside of our body, okay? So this I just wanted to show you here All right, what did I show you here? Look at this septal tricuspid valve leaflet, okay, and look at this chordae tendineae here. All right, and look at this chordae tendineae here as well. Okay, now all this chordae tendineae here didn't attach to papillary muscle. It is actually attached directly to interventricular septum. And as I remind you last time, this is the characteristic of the right ventricle, in which the chordae tendineae of the septal leaflet, part of it is really attached directly to the interventricular septum. Okay. More anatomy, okay, and this is interesting. If you were to look at the unfast view of the tricuspid valve, this again is a septal leaflet adjacent to the interatrial septum, anterior leaflet and posterior leaflet. Usually anterior is the biggest leaflet of the tricuspid valve. There is something that commonly called in electrophysiologist parlance that we call triangle of Koch. So what is triangle of Koch? So triangle of Koch is a very important triangle. So what is the border of triangle of Koch? The red part here is the septal attachment of the septal leaflet. This yellow here is the entrance of coronary sinus. So the coronary sinus enter from the back here into here. And this here, okay, is what we call a tendon of Todero. A tendon of Todero is just a small tendon, a small ridge at the side here. So tendon of Todero, the coronary sinus, and the insertion of the septal leaflet of the tricuspid valve. So this is called triangle of Koch. So why is this important? So this is important because when surgeon is doing procedure, or for example, if you are electrophysiologist and you do ablation, you wanted to try to avoid this apex of the triangle of Koch. Why? This is where your AV node is situated. Okay, if you were to disturb your AV node, you will develop complete heart block. Therefore, you have to try to avoid that. Furthermore, if you were to do tricuspid valve repair, so sometimes you have a severe tricuspid regurgitation and your tricuspid valve is big and you want to repair it, usually the ring is actually not complete. So the ring will be like that and you stop before it go and disturb the AV node, okay? Before it go and disturb the AV node. That's one reason. The other reason is because, another reason is the way the tricuspid annulus dilated when you have tricuspid regurgitation is actually throughout this part, anterior and posterior. The septal leaflet usually don't go anywhere because the interatrial septum prevented it from doing so. Okay, so I hope now you understand the triangle of Koch, all right, and also understand why we put a ring that is incomplete usually in the tricuspid annulus. Now the thing that I wanted to give you a tip is that the tricuspid annulus is only consists of the right atrial wall and the right ventricle wall, the border between the right atrium and right ventricle wall. It is not consist of fibrous tissue like the mitral valve annulus. So the tricuspid annulus dilated more easy than the mitral valve annulus. So when you have chronic atrial fibrillation, it is more easy to develop atrial fibrillation, to develop tricuspid regurgitation rather than mitral regurgitation. Right. Now, I just wanted to show you here, this is the anterior leaflet of the tricuspid valve. This is a septal leaflet of the tricuspid valve. Okay. Now, at the part of the endocardial cushion, in which mitral valve and tricuspid valve insertion, so when they insert together, that part here is consists of a membranous area. Okay. So we have a membranous area at the ventricle part here. And also on the right side, we have membranous area on top here. Okay. Now, if we have hole at the bottom here, you have membranous VSD. Okay. So you have a shunt from the left ventricle to the right ventricle. Unfortunately, okay, because mitral valve leaflet attach more basal and tricuspid valve leaflet attach more apically, you also have membranous septum here. Now, what happens if you have a hole here is you can have flow from the left ventricle into this hole into the right atrium. That is called Gerbode defect. Gerbode defect. G-E-R-B-O-D-E. Gerbode defect. Okay. The membranous septum, one is in left ventricular side, but part of the membranous septum is in the right atrial side. So therefore, if you have hole in this part, you can have shunt from the left ventricle to the right atrium. That is called Gerbode defect. Okay, that is, if let's say you have a hole there, it is perimembranous VSD. If you have the hole there, it is the top here, it is called Gerbode defect, right? This is one special thing about the right atrium. Remember that I tell you the chamber cavity of the heart is not defined by its spatial relationship, but rather by its unique anatomical characteristic. So this is a unique anatomical characteristic of the right atrium. Right atrium have pectinate muscles that go outside of the appendage into the wall of the right atrium. This is as opposed to left atrium, in which the pectinate muscle is confined into the left atrial appendage. So you have the pectinate muscle outside right atrial appendage in patient in the right atrium. And that arrow here is direction of dilatation in tricuspid valve annulus. Okay, so I just wanted to show you another example of tricuspid valve pathology. So the first tricuspid valve pathology that I show you is tricuspid valve stenosis secondary to rheumatic tricuspid valve disease. So this is actually apical 4-chamber view. This is actually a prolapse of the tricuspid valve. So prolapse does not only happen in the mitral valve, it also happens on the tricuspid valve. This is actually prolapse of the tricuspid valve. So which leaflet is this and which leaflet is this, I will teach you a bit later. Okay, so that's another pathology, which is myxomatous tricuspid valve disease. Now, I will just touch briefly about tricuspid stenosis because it is quite rare. So what is the common cause of tricuspid stenosis? So we have rheumatic. So rheumatic is not very common. Okay, it's much more common to have rheumatic mitral stenosis. We can also have carcinoid disease. But one tip for you, carcinoid disease causes more tricuspid regurgitation rather than tricuspid stenosis. Now, other cause of tricuspid stenosis is tumor that is obstructing the tricuspid stenosis. For example, you have angiosarcoma of the right atrium, you have myxoma of the right atrium. All this can obstruct the annulus of the tricuspid valve, causing tricuspid stenosis. In terms of hemodynamic findings indicative of significant tricuspid stenosis is mean pressure gradient that is more than 5 mm mercury, velocity time integral that is more than 60 centimeter, pressure half time actually that is more than 190 millisecond, and valve area by continuity equation that is less than 1 centimeter squared. For me, I just like to use for tricuspid stenosis the mean gradient that is more than 5 millimeter mercury. Okay, normally in tricuspid valve, if we want to repair, usually we just put a ring around the annulus. If we want to replace, most people will put a bioprosthetic tricuspid valve rather than metallic. Because of the low flow, they scared that in the right side of the heart, there is higher incidence of valve thrombus. That's why people like to use bioprosthetic tricuspid valve. Now, there is very important parameters when we do an echocardiogram. It is the tricuspid annulus size. Okay. Now, when we do operation on the left side of the heart, okay, anything that affect the left side of the heart, for example, you have mitral stenosis, you have aortic stenosis or regurgitation. So what happens is you have back pressure go back to the right side of the heart. When you have back pressure to the right side of the heart, you can cause what we call secondary tricuspid regurgitation due to left-sided heart disease. Okay. Now, the conventional belief in the time before this, meaning 1960s, 1970s, is once you correct the problem on the left side of the heart, the tricuspid regurgitation will go off by itself. Okay. However, now we know this to be not true. Okay. Even after we correct the left side of the heart, the right side of the heart, the tricuspid regurgitation will continue to progress. And we know that regardless of the degree of tricuspid regurgitation, if you have tricuspid regurgitation, your outcome is poor. Okay, if you have moderate, it is poorer than mild. Severe is poorer than moderate. Okay, so when do the surgeon know when they operate on the left side when to also touch the right side, the tricuspid valve? Okay, of course, if they have at the time concomitant severe tricuspid regurgitation, they will repair straight away because you know it's already severe. However, if it's not severe, how do the surgeon decide whether they wanted to intervene or not? So they measure the annulus. They see whether the annulus is dilated or not. Okay, so they measure from the anteroseptal to the anteroposterior commissure. They look whether it is more than 70 millimeter. If intraoperatively, this AS to AP commissure is more than 70 millimeter, they will repair this valve. However, as an echocardiogram, obviously we don't open the heart. All right, so we cannot tell the surgeon based on intraoperative finding. So we must based on echo finding. So based on echo finding, we use apical 4-chamber view at end diastole. We measure from here to here, and the diameter that is more than 40 millimeter, absolute diameter, or index to body area more than 21 millimeter per meter squared, in the presence of even mild tricuspid regurgitation, is recommended to repair. So for example, if your patient have severe mitral regurgitation and go for operation for severe mitral regurgitation, let's say they have concomitant mild tricuspid regurgitation, but the annulus is dilated, you need to repair that tricuspid valve. Okay, so that is the criteria. I hope you understand that. Okay, what about the attachment of the tricuspid valve leaflet? You remember that the left side of the heart, they have two papillary muscle, anterolateral papillary muscle and posteromedial papillary muscle. The anterolateral papillary muscle give chordae tendineae to the lateral part of the mitral valve, and the posteromedial give chordae tendineae to the medial part of the mitral valve. What about tricuspid valve? Tricuspid valve have three papillary muscle. What is the three papillary muscle? Anterior, posterior, and septal. Follow its namesake in the leaflet. So, the difference between the papillary muscle is like so. In anterior papillary muscle here, so asterisk, white asterisk, this is the anterior papillary muscle. It is the biggest papillary muscle. And it supplies chordae tendineae to anterior and posterior leaflet of the tricuspid valve, two leaflet. Anterior papillary muscle, anterior and posterior. You also have posterior papillary muscle here. Now you see posterior papillary muscle, it is actually smaller. And you can see in this patient, it is bifid. So you have two posterior papillary muscle, and you also have another one posterior papillary muscle here. So posterior papillary muscle is smaller. It is also variable in number. It actually gives it chordae tendineae to posterior and septal leaflet. Anterior give to anterior and posterior. Posterior give to posterior and septal leaflet. Okay. And last papillary muscle you have is this here. This is actually the septal papillary muscle. It is very, very small. The septal papillary muscle is actually give chordae tendineae only to the septal leaflet of the tricuspid valve. You remember, septal papillary muscle is very selfish. It only gives leaflet to the septal leaflet of the tricuspid valve. Okay, so that's the septal papillary muscle there. Right now, if you look at this side here, this is actually a zoom view of the right ventricle. Part of the septal leaflet of the tricuspid valve is attached to the posterior papillary muscle, and part of the septal leaflet of the tricuspid valve attached directly to the interventricular septum. Right. So just wanted to show you the three papillary muscle on the right side. Okay, the anterior, the posterior, and the septal, and also the attachment of septum, and also the attachment to the chordae tendineae of the septal leaflet of the tricuspid valve. Now, this is just the adjacent anatomy of the right ventricle. So I just wanted to draw your attention to this here, which is called the course of the right coronary artery. Now, between right atrium and right ventricle, the area here is called what we call AV groove. Now, the specialty about AV groove here, the primary malignant tumor of the heart called angiosarcoma, like to be in that right AV groove. Again, I show you the posterior papillary muscle there, and that is the anterior papillary muscle of the tricuspid valve. And that is the septal papillary muscle of the tricuspid valve. Okay, so I hope you understand so far what we talked to here. Okay, so let's catch up a little bit. Right, I have talked to you about the way right ventricle contract, mainly longitudinally. Don't forget the interventricular contribution to the right ventricular contraction. Now we have talked about the special criteria of the right ventricle. What makes right ventricle right ventricle? Okay. Now I also wanted to touch here the criteria. What makes the right atrium right atrium? So what makes the right atrium right atrium? Number one is the appendage of the right atrium is broad. Okay, they have a broad attachment. It is triangle shape and you have broad attachment. That's number one. Number two, the pectinate muscle in the right atrium actually go out from the appendage into the right atrial wall itself. That's number two. Number three criteria of the right atrium is the membrane secundum is on the right atrial part. Okay, the membrane primum is on the left atrial part. The membrane secundum is on the right atrial part. The other one is you see eustachian valve in the right atrium, and the IVC actually enter into the right atrium. So that is the characteristic of the right atrium. I just wanted to show you the cardiac cycle now because I wanted to understand, okay, if you take echo exam, you wanted to understand what is T index or myocardial performance index, okay? So let's see, we start looking at the cardiac cycle. Here I show the cardiac cycle on the left ventricle is the same on the right ventricle. So let's see at the end of diastole. So at the end of diastole, the pulmonary valve will close and the mitral valve is closed. So this is end diastole. At early systole, you have something called isovolumetric contraction. So what is isovolumetric contraction? The right ventricular pressure go up, okay, but the pulmonary valve and tricuspid valve is closed. So the pressure go up, but the volume stay the same. So that is an isovolumetric contraction. Okay. Now, as the right ventricle pressure go up and higher than the pulmonary artery pressure, then the pulmonary artery will open. Okay, but the tricuspid valve will stay closed. So blood will be ejected from the right ventricle into the pulmonary artery. So this is the period of ejection. All right. As it does that, the pressure at the end of ejection, the pressure inside the right ventricle will come down and come down. Okay. Then it will come down until to such extent that the aortic valve, the pulmonary valve will also close back. Okay. So the aortic valve then close back, and then you will go to early diastole. And at early diastole, the pressure inside the right ventricle go down and go down and go down, but the volume stay the same. That is the period of isovolumetric relaxation. And in isovolumetric relaxation, the right ventricular pressure will go down and go down and go down until the right ventricular pressure is lower than the right atrial pressure, and then the tricuspid valve will open, and then we have the right ventricular filling. Okay, so that is a complete cardiac cycle. So from here to here is systole, from here to here is diastole. Okay, there is something in echocardiogram called myocardial index, myocardial performance index, or T index. Now, what is T index? The index is very easy. It is isovolumetric contraction plus isovolumetric relaxation over ejection time. Okay, this plus this over this. In a normal heart, we want our heart to spend more time during ejection period rather than during the isovolumetric contraction or isovolumetric relaxation. So the value of T index, the lower it is, the better it is, the function of the ventricle. Okay, if you were to use pulse Doppler to calculate the T index, the normal value is less than 0.43. T index that is less than 0.43, if you use pulse Doppler, is normal. If you use tissue Doppler, that is less than 0.454 is normal. Unfortunately, you have to remember this number. But the concept, I hope you remember. We prefer the heart to spend more time during ejection than during IVRT and IVCT. So therefore, the ratio between ejection, the IVRT and IVCT over ejection, the smaller it is, the better it is. Now, what about the hemodynamic parameters on the right side of the heart? Okay, I just wanted you to remember this. Okay, now the right atrium, it is quite normal for all of us to have a right atrial pressure mean that is less than 3 to 5 millimeter mercury. Some people go around with right atrial pressure of 0. That is normal. So when you were to put in your CVP, that is actually measuring your right atrial pressure. This is opposed to left atrial pressure, in which the mean is about 8 millimeter mercury, that is normal. Anything above 50 millimeter mercury will cause pulmonary edema or shortness of breath. Now you see the left atrial pressure is always higher than right atrial pressure. Therefore, if you have atrial septal defect, the flow from left atrium and right atrium occur during systole and diastole, and this will cause right-sided volume overload. Right? You also see the A wave and V wave. What does A wave mean? A wave is pressure in the right atrium during atrial contraction, and V wave is pressure in right atrium during ventricular systole, usually mid to late ventricular systole, when the atrium is receiving blood from the pulmonary vein. The right ventricular pressure, the systolic is usually about 25 millimeter mercury, and the diastolic is about 4 millimeter mercury. Look at the left ventricle, the systolic is 130 and the diastolic is 8. Because the pressure difference is highest during systole, when we look at ventricular septal defect, the main flow as compared to VASD, for VSD, the main flow is during systole. As you can see here, the right atrial pressure and the RVEDP is the same unless you have tricuspid stenosis. The left ventricle and the left atrium, the LVEDP and the left atrial pressure is the same unless you have mitral stenosis. So if you cannot get left atrial pressure directly, you can just put your catheter inside the left ventricle and measure the left ventricular and diastolic pressure. You also can measure the left atrial pressure like that. All right. Now that is the peak systolic and diastolic pressure in the central aorta. Okay. Now if you have sinus or valsalva rupture, okay, the rupture can be into the right atrium, it can be into the right ventricle, or it can be into the pulmonary artery. Now, if you notice, doesn't matter where it rupture to, the differential pressure between the systole and diastole is present. So therefore, if you have a sinus or valsalva rupture, you always hear continuous murmur because murmur flow in systole and diastole. Also the same if you have pecten ductus arteriosus. So PDA is between descending aorta and pulmonary artery. So in PDA also, you all heard continuous murmur. Okay, I just wanted to show you as well, in the absence of pulmonary stenosis, the right ventricular systolic pressure is the same as pulmonary arterial systolic pressure. In the absence of aortic stenosis, the aortic systolic pressure is the same as left ventricular systolic pressure. Okay. Now we're going to go into measurement or dimension of the right ventricle. This you have to remember when you do echocardiogram, what is considered dilated. Okay, so D1, which is basal dimension, it should be less than 4.1 centimeter. All of these are end diastole. D2 should be less than 3.5 centimeter. And D3 should be less than 8.3 centimeter. Okay, you have to remember this. Now, when you have a short axis AOPA view here, this is a proximal right ventricular outflow tract. That is distal right ventricular outflow tract. Proximal must be less than 3.3 centimeter. And distal must be less than 2.7 centimeter. All right. Now, if you have pulmonary hypertension, you can also have eccentric index. Normally, the diameter D1 here is the same as D2. However, if you develop pulmonary hypertension and the interventricular septum become flat, this D1 will be longer than D2. So, the higher the eccentricity index, the worse your right ventricular systolic pressure is. Okay, remember this number. Okay, this will be asked in the exam. And this measurement must be done in RV focus view. I will show you what is the RV focus view later. Now, this is the appearance of interventricular septum, and the appearance of interventricular septums, okay, sometimes is confusing. What is the difference between volume overload of the right ventricle and pressure overload of the right ventricle? In volume overload of the right ventricle, during diastole, the septum is flat. However, during systole, it becomes round again. Diastole, it is flat. Systole become round. That is the volume overload of the right ventricle. Now, pressure overload of right ventricle, it is flat in diastole and also flat during systole. This is paradoxical septal motion. The term paradoxical septal motion, we leave it for right-sided volume overload. Okay, flat during diastole, rounded during systole. That is septal motion. Remember, there is difference between septal and right-sided volume overload, right-sided pressure overload, constrictive pericarditis, left bundle branch block, Wolff Parkinson White. There's a lot of different, okay? But I think it's important to know at least the difference between volume overload and pressure overload. In terms of comprehensive assessment of right ventricle, whenever you do echocardiogram, you have 14 views if you want to have comprehensive assessment of right ventricle. Now, this is all the comprehensive view here. Okay, why do you want to do comprehensive view? Because you want to see all the right ventricle wall. You don't want to miss any of the wall. You want to see all the leaflet. Okay, and you have to do a correct measurement. Okay, this is our normal apical four-chamber view. You see that it is straight. Okay, this is important. But in terms of measurement, the most important is this. This is RV focus view. So you want to move your probe laterally, meaning more lateral. Okay, in fact, you have even sometimes your table can have a drop down thing. Okay, and this is the best place to measure. It is called an RV focus view. So you measure our basal, mid, and longitudinal dimension here. This is a modified apical four-chamber view. This is good to see tricuspid vegetation. All right, this is a five-chamber view. Whenever you see aorta here, okay, whenever you see aorta here, this leaflet at this side, okay, it is an anterior leaflet. All right, what about the leaflet of the tricuspid valve? Here, because you see the aortic valve, this is actually the anterior leaflet. So that is a septal leaflet. That is the anterior leaflet of the tricuspid valve. Whenever you see coronary sinus, this is the septal leaflet. Okay, this is the posterior leaflet. All right, this is anterior here. This is posterior here. All right, so that is in apical four-chamber view. The more anterior you are, you see the anterior leaflet. The more posterior you are, you see the posterior leaflet. All right. This is a subcostal four-chamber view. This is a subcostal AOPA view. This is very good to get a parallel relationship with pulmonary valve. This is the parasternal long axis view. If you measure from here to here, it is a proximal right ventricular outflow tract diameter. Remember, the upper value is 3.3 centimeter. If you measure from here and here, that is the distal right ventricular outflow tract. Now, this is an RV inflow view, okay? In RV inflow view, if let's say you don't see left ventricle here, okay, you only see the wall of the right ventricle, so that is the inferior wall of the right ventricle. So this leaflet here will be posterior leaflet, and that will be anterior leaflet. If you don't see right ventricle, this is the posterior, this is anterior. If you were to see right ventricle, okay, what about this one? If you were to see the left ventricle here, this leaflet here is septal if it is short, it is posterior if it is long, okay? What about in AOPA VO view? In this view, if you can see both leaflet here, this is anterior and this is posterior. If you can only see one leaflet, that is anterior leaflet. If you start to see left ventricular outflow tract, then that is septal and that is posterior leaflet. Okay, I will show you again a bit later. I just wanted to remind you the importance of RV focus view in terms of doing measurement. Okay, now this is what I tell you just now. Okay, now this is one of the most important thing that I wanted to remember. Now let's say you do your AOPA view. Okay, this is AOPA. So that's aorta, left atrium, right ventricle, and pulmonary valve. Okay, now depend on how you tilt your probe. If when you tilt your probe, you see that it is only a single leaflet mainly going here. Okay, and it's very little leaflet is seen there. Okay, most of its majority is one leaflet. That is anterior leaflet. Okay, if you tilt a little bit and you see two leaflet here that is almost the same size, this is anterior and this is posterior. Okay, this is anterior and this is posterior. If you tilt a little bit and you start to see left ventricular outflow tract, okay, this is septal and this is posterior. Okay, so it depends on how you tilt. Most of the time you will see this. Okay, if you see this, simple, anterior, posterior. If you see one, big one, anterior. If you start to see LVOT, that is actually septal and that is posterior. Okay, so it's a good place to see posterior leaflet because all of this and this is posterior leaflet. Okay, I hope you understand. Okay, because the difference in our cutting view. So it's not straightforward. What about if you look at RV inflow view? So RV inflow view, so what happened in RV inflow view? If you see this RV inflow and you don't see the interventricular septum, okay, you just see the inflow view, all right, and you see the interventricular septum here, right, that's the left ventricle, and you see the interventricular septum, this is actually the septal leaflet. So whenever you see the left ventricle here, that is actually the septal leaflet there. Now that's the eustachian valve, that's the septal leaflet. If you don't see the septum, okay, if you don't see the septum, okay, if you see here and it is short, it is a septal leaflet. If you see here and it is long, it is posterior leaflet. Okay, one more time. If you see the left ventricle, meaning that this is the interventricular septum, you know that this is septal leaflet. If you don't see the left ventricle, okay, the way to differentiate is if the leaflet is short, it is a septal leaflet. If the leaflet is long, it is the posterior leaflet in an RV inflow view. This is always anterior leaflet here. Okay, so that is how we decide in RV inflow view. You see, it's different from the way we learned before. All right, what about apical four-chamber view? The more anterior we are, this is anterior leaflet of the tricuspid valve. The more posterior we are, as we see coronary sinus, that is the posterior leaflet of the tricuspid valve. So this is anterior, this is posterior. We know this is septum because this is interventricular septum. All right. So let's look at this one. Okay. Now, ladies and gentlemen, what do you think is the diagnosis of this echocardiogram? So what is the diagnosis of this echocardiogram? All right. You can see that the leaflet is actually retracted. Okay, it's retracted. It doesn't move. Okay, what is that? This is carcinoid tricuspid valve disease. Carcinoid tricuspid valve disease. If I were to ask you which leaflet is this and which leaflet is that, okay? So how do you know, right? Look at this. So you can see interventricular septum here. So you can see the right ventricle, the left ventricle here, interventricular septum there. So if you see interventricular septum, what leaflet is that? So that's going to be a septal leaflet. That's going to be anterior leaflet of the tricuspid valve. All right. So that is going to be a septal leaflet, and that's going to be anterior leaflet. Why septal? Because you see the interventricular septum, the left ventricle there. This is the coronary distribution of the right ventricle that cover the right ventricular wall. I hope you can remember this. Okay, it took me a long time to remember. Now I can. Okay, so the inferior wall of the right ventricle. So the RV inflow view is one of the unique view. You see the RV inferior wall. Okay, this is supplied by the PDA branch of the right coronary artery. Now this anterior and the RV free wall is actually supplied by the marginal branch of the right coronary artery. Okay. You can see this basal septum of the right ventricle is supplied by the PDA branch of the RCA. However, the mid and apical septum and also the moderator band is actually supplied by the LAD. All right. One more time, PDA branch of the RCA is the inferior wall and the basal septum. Marginal branch of the RCA is the anterior wall and the lateral wall. And the cornus branch, you can see there at the RV outflow tract here. You can see the corner branch of the RCA. All right. So where do you measure the right ventricular wall thickness? You measure at subcostal four-chamber view. This is subcostal four-chamber view. That's LV and RV. You zoom at the RV wall and you measure the thickness in diastole. And anything that is more than 5 millimeter is considered abnormal wall thickness. So this is the dimension here. Okay, I asked you to remember already just now what is what. So this is 4.1, this is 3.3, okay, and that is 2.7 there. Right? So remember that. All right, one more time to show you where do we measure. All right, so if you want to take a look at that. All right. So why right ventricle? It's very important. Don't forget right ventricle. We need both sides of the heart to work properly. Poor right heart function, so any disease, even if it only affect the left ventricle, it affect the right ventricle, it gets poorer prognosis, and echo assessment is more challenging. Now in echo assessment, I only want you to remember a few numbers. Number one, TAPSE. TAPSE is tricuspid annular plane systolic excursion, meaning that how far the tricuspid annulus move during systole. The further it moves, the more normal it is. So anything that is more than 1.7 centimeter is considered normal. Now, not only we measure TAPSE, we measure the distance. We wanted also to measure the velocity, how fast that is go. So anything that is more than 9.5 centimeter per second, S prime is considered normal. What about fractional area change? Remember I tell you, right ventricle from 2D, we cannot measure ejection fraction because we don't have any geometrical assumption for right ventricle. Therefore, but we can do fractional area change. So we trace the area during diastole, minus the area during systole, divide the area during diastole times 100%. The normal value for RV fractional area change is 35%. The EF is 45%, normal for RV, but we cannot do it from 2D. Either we use 3D echo or we use cardiac MRI. And myocardial performance index, and now you are not confused already. You know MPI is IVCT plus IVRT over ejection time. The lower it is, the better. So if you use pulse wave Doppler, less than 0.43 is normal. You use tissue Doppler, less than 0.54 is normal. EF is 45%. Now strain, I talked you just now, okay, is new value. If you only use lateral RV wall, it's negative 19%. If you use lateral wall and also interventricular septum, it's negative 17%. All right. If you were to characterize the right heart, okay, you put the catheter inside the right atrium, you can see the wave in the right atrium. A is atrial contraction. Okay, C is at the very beginning of systole when the tricuspid valve close. X descent is at the moment of atrial relaxation during early systole. V wave is at mid to end right ventricular systole when the right atrium is filled by the pulmonary vein. So if you have tricuspid regurgitation, you have giant V wave. Why? Because there's a lot of blood filling your right atrium at the same time as pulmonary vein filling your right atrium. and this Y is Y descent. What is Y descent? It is at early diastole after isovolumetric relaxation time, when tricuspid valve open and the blood flow rapidly from the right atrium to the right ventricle. If we were to push the catheter into the right ventricle, we'll see the right ventricle pressure loop here. So you have a right ventricular systolic pressure and right ventricular diastolic pressure. And this diastolic pressure is the same as right atrial pressure in the absence of tricuspid stenosis. And you can see that the right ventricular systolic pressure approximates pulmonary artery systolic pressure in the absence of pulmonary stenosis. Now, if you then go and wedge, you push your Swan's guns all the way in and wedge the pulmonary, you actually will get the left atrial pressure. Remember, the left also have its own A, C, X, V, and Y. So how to remember this? Okay, my friend showed me this mnemonic, which is ridiculous, but make me remember. Okay, the mnemonic is called Anderson, Cooper, and Van der Witt Yale. Okay, so Anderson Cooper is, I think, the CNN host. Van der Witt Yale, I think, one of their philanthropic or something. So A wave, C wave, N is X, Van der Witt is V, and Yale is Y. A, C, X, V, and Y. In echocardiogram, and this will definitely come, is the calculation of pulmonary artery pressure. Definite times 100% plus CHOP. Definitely will come in your exam. Okay, how to measure the pulmonary artery pressure? If you have tricuspid regurgitation velocity, okay, and you have the gradient, you know that RV systolic pressure minus RA pressure is equal to TR gradient. So TR gradient plus RA pressure is RV systolic pressure, and RV systolic pressure is the same as pulmonary systolic pressure in the absence of pulmonary stenosis. That is what we do day in and day out. Okay, that is one. There is also other way. That is how we calculate systolic pulmonary artery pressure. Okay, we also can calculate diastolic pulmonary artery pressure by using pulmonary regurgitation and diastolic velocity. Okay, you measure the PR and diastolic gradient, add that to RA gradient, RA pressure, and you get pulmonary diastolic pressure. Okay, you can also use the peak pulmonary artery pressure to calculate the mean pulmonary artery pressure. So the peak pulmonary pressure, the peak diastolic pressure gradient plus RA pressure is equal to mean pulmonary artery pressure. So see the subtlety between systolic and mean. However, okay, the real diagnosis of pulmonary hypertension is done in catheterization of the right heart. The definition is mean pulmonary artery pressure more than 25. So what we do is we screen using an echo. So anyone with systolic pulmonary artery pressure that is more than 40 millimeter mercury, send them to right heart cath, estimate the diagnosis of pulmonary hypertension, then you can follow them up with echocardiogram. Don't need to do right heart catheterization anymore, right? So what else can you see when you want to look for someone with pulmonary hypertension? Let's say you don't have tricuspid regurgitation. What you can do is you can look at the pulse wave Doppler of the pulmonary valve here, and you can look how fast does it go from the opening click of the pulmonary valve to its maximum flow, and look at acceleration time. Okay, the shorter the acceleration time, the more likelihood you have pulmonary hypertension. So if your acceleration time is less than 90 milliseconds, you have a quantitative indication that you have pulmonary hypertension. Okay, that's one. You can look from here. Another thing that you can look is, don't have in this Doppler, but a notching at the mid segment of the flow here. That is also a sign of pulmonary hypertension. And lastly, if you were to do an M mode, remember, not Doppler, M mode across the pulmonary valve, you can see something that is called flying W. It's something like that. Okay, that is also pulmonary hypertension. I will show you after this. So remember, few things that you need to remember. Measure the systemic pulmonary artery pressure from peak TR gradient, diastolic pulmonary artery pressure from NPR gradient, mean pulmonary artery pressure from peak PR gradient. Okay. So this is an example of someone with pulmonary regurgitation. Okay. Now this two is N diastolic gradient. You can see that the gradient is 20.97. So this 20.97, let's say you take RA pressure of 8 millimeter mercury. Okay. So 20 plus 8 is 28.9. So that 28.9 is pulmonary artery diastolic pressure. Okay. That is pulmonary artery diastolic pressure. If you were to use the peak of pulmonary regurgitation, you see the peak is 37. Let's say the right atrial pressure is 8, 37 plus 8 is 55. So that 55 millimeter mercury is the mean pulmonary artery pressure. So you use this, you got diastolic pulmonary artery pressure. You use this, you got mean pulmonary artery pressure. Okay. What about if you use peak TRZ here, you get systolic pulmonary artery pressure. You will see that the peak TRZ here is 31 millimeter mercury, assuming the RA pressure is 8, 31 plus 8, 39. So systolic pressure is 39. So you use this as systolic pulmonary artery pressure surrogate. Okay, I hope you understand that guarantee will come out. Okay, now if you have pulmonary hypertension, sometimes you wonder, okay, you know that pulmonary hypertension is divided into 5. Class 1 is pulmonary arterial hypertension. That's your idiopathic pulmonary hypertension secondary to congenital heart disease. Then you have type 2, secondary to left-sided heart disease. You have type 3 because of lung disease, type 4 because of chronic thromboembolism, and type 5 is miscellaneous. Out of all these 5, only type 2 is because of left-sided heart disease. Now, if you judge from echo, how you want to differentiate between type 2 and the rest. So there is something that is called EPLA, echocardiographic pulmonary to left atrial ratio. So what happened is you divide the TR Vmax in meter per second over E over E prime. Now E over E prime is a surrogate of LA pressure. Okay, the higher the value of TR over the E over E prime, the more likely for you to have pre-capillary hypertension. The lower the value, the likely you have to have post-capillary hypertension, and we take the threshold as 0.3. So if EPLA is higher than 0.3, you are having a pre-capillary pulmonary hypertension. If EPLA is less than 0.3, you have post-capillary pulmonary hypertension. Okay. All right. Now, what about myocardial performance index? Okay, there is 2 ways. Okay, listen carefully. There is 2 ways. One is by using tissue Doppler. If you use tissue Doppler, we only have to measure in 1 cycle. Use apical 4-chamber view here, and you put your tissue Doppler there. Make sure your sample volume for tissue Doppler is at least 3 to 5 millimeter in terms of the sample volume. Okay, then you can get this kind of tracing here. This kind of tracing here. What happened is, from here to here, okay, this part here, this is actually isovolumetric contraction. Okay, from this ending to the start of here, that is actually isovolumetric relaxation. Okay, in the middle here is ejection time. Okay, so this distance, isovolumetric contraction plus isovolumetric relaxation over ejection time is T index if you use tissue Doppler. In this case, if it's less than 0.54, it is considered abnormal. Okay, it is considered abnormal. Another way is to use pulse Doppler. If you use pulse Doppler, what happens is, okay, you can use the inflow of your tricuspid valve. Now, when you use the inflow of tricuspid valve, if you have tricuspid regurgitation, the tricuspid regurgitation flow is the time from the tricuspid valve closure to tricuspid valve opening. Okay, so you measure the regurgitation time, the time from closure to time of opening. Okay, but you have to go for another cycle because you need to go to pulmonary valve to measure the pulmonary valve ejection time. Then you measure that ejection time from the pulmonary valve. So the 4-chamber view, you measure the tricuspid valve, the time from closure to opening, and then you go to pulmonary valve, the time the blood ejecting from the pulmonary valve. So this time here minus this time here, you know, is isovolumetric contraction plus ejection time. So if this time here, so TCO minus ejection time over ejection time, that is a T index using pulse wave Doppler. Okay, and for that the value is less than 0.43. Okay. However, the myocardial performance index, the advantage is also most of the RV index is a systolic index, but MPI take into account the diastolic period as well, because remember we take into account isovolumetric relaxation time. Okay. Now, however, it is not without its problem. Okay, this is some of its problem. It makes systolic and diastolic function. It is a problem, and also it is advantage. It can vary with pressure and volume status, and make sure we don't measure pre-systolic time in terms of ejection. Okay, we don't want to include isovolumetric contraction in our ejection time measurement. Okay, so few of example that something might be misleading. So for example, let's see, we see this patient. Okay, so this is the patient initially. Okay, now however, sorry, this is the patient initially. You can see that the aortic pressure is high. So let's say we give some medication. and the medication actually reduce the pulmonary artery pressure. So when the medication reduce the pulmonary pressure, you can see that the IVRT is actually coming down as well. Not only the pulmonary artery pressure come down, okay, the IVRT also come down. Therefore, your T index will be artificially lower. Okay, so there is nothing changes with the RV itself. You're only changing the pulmonary artery pressure acutely with medication, but your T index changes. Okay, and that cannot be attributed solely on the RV function. Okay, that is the caveat. Right. So, for example, the normal myocardial performance index might be 0.6x, which is abnormal. If you use the pulse wave Doppler, must be less than 0.43. However, if you give less 6, the pulmonary artery blood pressure might go down. The T index might go down, but that might just be artificial. Okay. Same goes for if you change patient atrial pressure. So this is the atrial pressure, this is elevated. You can see that the atrial pressure actually go down from here to here. However, as the atrial pressure go down, the IVRT actually go up. So in this situation, the T index actually go up without any intrinsic changes in RV performance, right? So maybe your real T index is 0.96, is abnormal, okay? But when you give something to reduce the pressure, the T index actually go higher, all right? So you have to be aware of this caveat. But most of the time, this wouldn't affect so much, so we can use T index. This is an example of how you measure fractional area change, area in diastole minus area in systole over area in diastole times 100. 60% is normal, 20% is abnormal. This is TAPSE. Put an M mod across the tricuspid annulus here and just measure the height. Not this way, but the height. The height. Anything that is above 1.7 centimeter is normal. Okay, 1.6 is the old guideline. The new guideline is 1.7. Now this is the flying W sign. Okay, that is the flying W sign. If you put your M mod across the pulmonary valve, if you see this pulmonary W sign, even if you don't have TR, even you don't have PR, this is the sign of pulmonary hypertension. Okay, there is other sign for pulmonary stenosis and also sign for sinus rhythm as well. Okay, don't confuse it with the signs of pulmonary hypertension. In pulmonary hypertension, you don't see any contribution of right atrial contraction to the movement of the pulmonary valve, because the pulmonary pressure is so far higher than the right atrial pressure. All right, so I just wanted to show you how we measure. Okay, this is patient with hypertrophic cardiomyopathy. Now, if I were to measure that area, if I wanted to ask you what measurement I measure there, that is the proximal right ventricular outflow tract. Normal is less than 3.3 centimeter. Anything that is more than 3.3 centimeter is considered dilated. So let's say, for example, you are in the emergency department, patient comes with sudden onset of shortness of breath and not known to have any issues. So if you measure and suddenly, let's say that measurement is 4.4. So there is indication of RV dilatation. So be suspicious of pulmonary embolism. Okay. Now, if I were to measure the distance of this arrow here, what would I measure? Okay, so that is what I call TAPSE. How far does it goes up? Anything that is more than 1.7 centimeter is normal. Not only I can measure TAPSE, if I put a tissue Doppler, I also can measure velocity. Anything that is above 9.5 centimeter per second is normal. Okay, so we can measure TAPSE and we can also measure S prime here, right? Now, what is this? This is a subcostal four chamber view. Okay, what am I doing here? Okay, try to guess yourself, think it in your mind. So let's say I zoom here and I see that is how we measure our right ventricular wall thickness. Remember always to zoom and we measure the right ventricular free wall here, how thick it is. Anything that is more than 5 millimeter is considered abnormal wall thickness. And incidentally, you can also see this flow here. This patient also have ASD with left to right shunting. Okay. Okay, what about this one? Look at this patient here. That is the left ventricle and right ventricle here. Okay, what I wanted to see you. In normal people, the right ventricle should be smaller than the left ventricle. In this patient, the right ventricle is much bigger than the left ventricle. So the right ventricle is dilated. Okay. Now, furthermore, as you can see, the apex of the right ventricle is contracting quite vigorously. You see that? As if it's winking to you, but the mid segment is not so much. So this is a McConnell sign. Okay, and what about the septum? You can see that the septum is flat in both systole and diastole. So this is right-sided pressure overload. So if someone come with you acutely like this, be suspicious of pulmonary embolism. Okay, however, if it's not pulmonary embolism, it might just be pulmonary hypertension. Then you have to find what is the result of that pulmonary hypertension. Okay. So severely dilated RV with hyperkinetic apex with mecanal signs, and also septal motion due to right-sided pressure overload. Flat in systole and also flat in diastole. All right. Now, what about this echocardiogram here? Look at this. This is the left atrium, left ventricle, right atrium, and right ventricle. Look at this right ventricle. What about the size? Now, this size is normal. If you see the right ventricle, it is much smaller than left ventricle. In summary, the right ventricle should be less than 2/3 the size of left ventricle. Okay, so this right ventricle is small. However, look at the right ventricle function in terms of the contractility. Is it okay or not? So we see whether the longitudinal contraction is normal or not. So what I do is I use TAPSE. So use M mode to measure the tricuspid motion. So the motion is from here to here. And I measure it is only 1.3 centimeter. So it is abnormal. This patient have right ventricular systolic dysfunction, and the value is only 1.3 centimeter. I can also measure the S prime to see whether it is less than 9.5 centimeter per second. I can also measure the myocardial performance index or T index. If I use blood pulse Doppler, it should be less than 0.43. If I use tissue, it should be less than 0.54. That is actually a pacemaker lead there. Okay, you can see a pacemaker lead from the right atrium going into the right ventricle. Right? So this is a poor right ventricular contraction, and note the lead inside the right ventricle. Okay, so this patient actually have prosthetic mitral valve. This is an old type prosthetic mitral valve. We don't use it anymore. This is a ball and cage. There's 3 types of metallic mitral valve: bi-leaflet, single tilting disc, and ball and cage. We don't use ball and cage anymore. We hardly ever use single tilting disc. So most of patients now have bi-leaflet metallic valve. Now, what about this echocardiogram here? Okay, if someone can tell me what are they seeing? Okay. Look at the septal. Look at the septal movement. Okay, right. It move towards the left side on inspiration, inspiration, expiration, inspiration, expiration, inspiration, expiration. So those of you who have come to see my talk before, septal shift with respiration exaggerated. What is the first thing you need to remember? Need to think of constrictive pericarditis. Okay, so this is a patient constrictive pericarditis. Not only this patient have septal shift, this patient also have diastolic septal bounce. Okay, not the movement of the septum to the left and to the right with respiration, but the movement at every beat is like that. Okay, you see that every beat the septum move like this. Okay, that is diastolic septal bounce. Okay, so this is a patient have beat to beat early diastolic bounce and also septal shift. The patient have both phenomenon here in constrictive pericarditis. So what I wanted to do here, so this is an AOPA view. So that's aorta there. That's pulmonary artery, right and left pulmonary artery. What do I want to do here? Okay, if I measure this part, what am I measuring? I measure proximal right ventricular outflow tract. I want to make sure that it's not more than 3.3 centimeter. If I measure there, I'm measuring distal right ventricular outflow tract. I want it to be no more than 2.7 centimeter. Okay. Right. What about this one? Okay, this is someone with hypertrophic cardiomyopathy as well. Left atrium, left ventricle, right ventricle. Now I'm actually measuring the annulus of the tissue Doppler. All right, the tricuspid tissue annulus. All right. Now, even though this is the measurement on the left ventricle, but the concept is the same for the right ventricle. Look at this. This is T index using tissue Doppler. That box there is isovolumetric contraction time. That box there is isovolumetric relaxation time. That arrow there is ejection time. So isovolumetric contraction plus ejection plus isovolumetric relaxation over ejection time. For tissue Doppler, it must be less than 0.54 for the right ventricle. Anything that is more than 0.54 is abnormal. I show you a tissue Doppler now. Okay. Oh, sorry, this is someone with cardiac amyloidosis, right? Okay, what about this patient? Okay, is the right ventricle enlarged or not? Okay, so if let's say you cannot answer this question, I don't know what to say. Left atrium, left ventricle, right ventricle. How do I know that it's right ventricle? Not just because it's on the right side. What else? Because you see the patient got moderator band. So patient moderator band is a characteristic of the right ventricle. What else? You see the septal leaflet of the tricuspid valve is actually attached more apically, more apical compared to the here. So I know this is tricuspid valve. So I know this is right ventricle. So this patient, right ventricle is very dilated. What do you think about the function? Okay, you can see that the function is abnormal without measuring it. You can see the smoke here. The smoke here is a spontaneous echo contrast. All right. So you severely dilated RV with spontaneous echo contrast in someone with locked sunding pulmonary hypertension. This is most likely a septal leaflet of the tricuspid valve. This is most likely the anterior leaflet of tricuspid valve that is flailing. Right? All right, what about this one? Okay, this is an RV inflow view. If you look at the RV inflow view here, this is pericardial efficient. You don't see left ventricle here. Now, if you don't see left ventricle here, all right, if you don't see the left ventricle here, this is either septal leaflet or posterior leaflet. All right, how do I want to know? So I wanted to see whether this leaflet is long or short. If this leaflet is short, this is septal leaflet. If this is long, this is posterior leaflet, right? Now, what else does happen? So you can see that this is RV cavity here, but there is a small neck here. Okay, there's a rupture something in small neck, and there is a cavity here. So whenever you see a cavity with a small neck, this patient have a rupture of the right ventricular myocardium with a pseudoaneurysm, right? So that is pseudoaneurysm. Okay, you can also see this is actually the eustachian valve here. Somewhere here is IVC, somewhere there is SVC. That is the anterior leaflet, all right? Now, that is anterior leaflet, all right? Now, because I think that this look a bit shorter, all right? Sorry, I see that this is a bit longer. So if it's longer, it is posterior. So I think that this is posterior leaflet. So this is anterior leaflet, and that is the posterior leaflet. Remember, in RV inflow, if you can see the left ventricle, this is septal leaflet. If you cannot see a left ventricle, it's either septal or posterior, but septal is shorter, posterior is longer, right? Now, what about this echocardiogram here? Anyone can tell me what is the problem here? All right, look at this RA, huge RA, okay? Look at this. This is the eustachian valve, okay? That's the eustachian valve there, okay? What is on top of eustachian valve? On top of eustachian valve, that's coronary sinus, okay? That's coronary sinus. What about there? That is right ventricular cavity. You can see that there is no coaptation at all. There's big hole there. Even not looking at the color, we know the patient got severe tricuspid regurgitation. Okay, that is the AOPA view of the tricuspid of this aortic valve. That's pulmonary valve. You can see the patient also have pulmonary regurgitation. So the patient have a very big RV dilatation. All right, very big RV dilatation. Now you don't see any left ventricle here. So there's no left ventricle. So what leaflet is that? Now, there is no left ventricle, so that must be the posterior leaflet. That is the posterior leaflet of the tricuspid valve. That is the anterior leaflet of the tricuspid valve. Why is the RV dilated? Now, what is this? You can see a continuous flow from this structure here into the left main pulmonary artery. Continuous flow from here to the left main pulmonary artery. So what is that? So this is someone with patent ductus arteriosus. Connection from the descending aorta to the left main pulmonary artery. So patient with PDA, at the beginning, they will have left-sided volume overload. However, if left untreated, they will develop pulmonary hypertension and right-sided pressure overload, and they will develop tricuspid regurgitation, like what this patient have. Okay, so this patient have right ventricular pressure overload secondary to patent ductus arteriosus. So dilated RV and tricuspid annular dilatation. That is anterior and that is posterior tricuspid valve leaflet, right? Now, this is the tricuspid regurgitation. So, what is the systolic pulmonary artery pressure? Remember, systolic pulmonary artery pressure is TRV max, the maximum gradient. So, the maximum gradient is 72.8 plus IVC. So, IVC, we look at IVC. The IVC, if it's less than 2.1 centimeter and more than 50% collapsible, is 3 millimeter mercury. If it's more than 2.1 centimeter and less than 50% collapsible, it is 15. Anything in between, it is 8. So let's say we assume that this patient right atrial pressure is 8, 72 plus 8. So the systolic pulmonary artery pressure is 80 millimeter mercury. Okay. What if I want to know what is the T index? I can also do in this thing, I can do pulse Doppler because I have tricuspid regurgitation here. So what I can do is I can measure from tricuspid valve closure to tricuspid valve opening, right? This is inclusive of isovolumetric contraction, ejection, and isovolumetric relaxation. I can measure this period all. I can go to pulmonary valve and measure pulmonary valve ejection time. So this time minus pulmonary valve ejection time over pulmonary valve ejection time, that is T index using pulse wave Doppler, and less than 0.43 is normal. Right, so in same patient as previously, the arrow shows the duration of TR, i.e. from tricuspid valve closure to tricuspid valve opening. If we measure RVOT ejection time from the pulmonary valve, then we can calculate the blood T index, right? Normal value is less than 0.43. Now look at this patient here. All right, this echo parasternal long, this is a parasternal long axis view of the patient. Okay, that's a parasternal long axis view of this patient. Okay, now look what this patient have. Okay, look at this. Okay, this is proximal right ventricular outflow tract here. Okay, what do you think about the proximal right ventricular outflow tract here? Look dilated, isn't it? So what we do is we measure, is it dilated or not? If it's more than 3.3 centimeter, it's dilated. When we see it's dilated, you wanted to know what is the reason my RV is dilated. You can look at interventricular septum, it is pressure or volume overload. So in this case, it is a volume overload. Now, if you look at the subcostal four-chamber view, I can see the red flow. Okay, blue is away and red is towards the transducer. We can see flow from the left atrium to the right atrium. This patient gave right-sided volume overload secondary to atrial septal defect, right? So RV dilatation, secondary secundum ASD with left to right shunting. All right. Now, how do you quantify tricuspid regurgitation? Usually we use quantitative color Doppler. We can also use PISA, just like we use MR, but it's not as robust. The value of EROA is same as MR, 0.4 centimeter squared is considered severe, but regurgitation volume is different. For mitral valve is 60, for tricuspid valve is 45. Okay, another thing that you can do is can you measure PISA. PISA for TR severe is 7 and the same as mitral regurgitation, right? For severe EROA of 0.4, the corresponding regurgitation volume is 45 in tricuspid regurgitation, not 60 mils. All right. You can also not only mention the tricuspid regurgitation severity, now we have mild, moderate, severe, and some people also now use massive and torrential because sometimes the RA can be so big. What happens is not only you can see the TR severity, you also can include the diameter of the annulus and whether the leaflet is coapting or not in your echocardiography report. All right. So thank you very much. I thought that this is going to be a short talk, okay, but you know my talk. But, so this is the take-home messages, and I hope you really find interesting the right ventricle, the right ventricular anatomy, what defines right ventricle, what defines right atrium, how many leaflet does the tricuspid valve have, how many papillary muscle, where does the chordae attach, what is triangle of Koch, what is T index, all the parameters of the right ventricle, how to tell which leaflet is the septal, anterior and posterior leaflet, try to tell whether the patient have pressure or volume overload, you know. So I think my message here and my aim is good, right? So I hope all of you can see these take-home messages about number. If you cannot just remember this T, TAPSE 1.7 is abnormal, fractional area change less than 35% is abnormal, T index for pulse wave less than 0.43 is normal, more than 0.43 is abnormal, for tissue more than 0.54 is abnormal, for the tissue velocity less than 9.5 is abnormal. Remember that tricuspid regurgitation have few causes, okay? It can be because of pressure overload, secondary. It can be secondary volume overload. It can be just because the right ventricle itself is diseased. It can also be because of chronic tricuspid regurgitation. Always try to find underlying cause of right heart dysfunction. Know how to calculate pulmonary artery pressure. This will come out if you take exam. This will definitely come out. Remember, TR is systolic pulmonary artery pressure. PR and diastolic is diastolic pulmonary pressure, and peak diastolic is mean pulmonary artery pressure. Shock acceleration time is a marker for pulmonary hypertension. Remember how to estimate RA pressure from IDC. I repeat again, less than 2.1, more than 50% collapsible is 3, more than 2.1 centimeter, less than 50% collapsible is 15, anything in between is 8. Now, thank you very much, ladies and gentlemen, for your patience. We will do next talk next week. I will tell you the title. Thank you very much, and feel free to ask whatever question that you wanted to ask. Thank you very much.